Well, good afternoon to all viewers. Today we are going to discuss one case who appears to have some hematological problem, and this is from Kalawati Children's Hospital at Lady Hardinge Medical College. One of the postgraduate student, Dr. Preetham, is going to present this case, and we are three faculty members here. I am Dr. Jagdish, Dr. Mehato on my right side, and Dr. Pyali Mandal. So, can we start the history? Yes.
Good evening, everyone. I'll be presenting the case of Mohit, 9-year-old male child. He is resident of Ghitoni village near Mehrauli, Delhi. Informant is mother and she is reliable. Child was apparently well 6 months back when he developed progressive pallor for 1.5 months, decreased appetite for 1.5 months, bluish purple spots all over the body for 10 to 15 days. Since 1.5 months, mother noticed progressive paleness of...
So, you mean 6 months back
Yes, sir.
he presented for the first time here?
Yes, sir.
So,
Since
say
some
that
other hospital, he did not present it here for the
Okay.
first time. Only 2 months back he presented to this hospital.
Alright, so 6 months back when he presented to other hospital, he had the symptoms already for 1.5 months,
Yes, sir.
right?
Yes, sir.
So means the duration of illness is almost 7.5 months. or so.
7.5
Right.
months.
Okay.
So again, repeating the presenting complaints, progressive pallor for 1.5 months, decreased appetite for 1.5 months, and bluish purple spots all over the body for 10 to 15 days. This was noticed by mother as increasing paleness of the body associated with easy fatigability and exertion on playing or climbing stairs, and it was associated with decreased appetite. Later on, after a few days, child also developed bluish purplish spots all over the body of variable size, ranging from 25 paise coin to 50 paise coin, and it was not associated with trauma or bleeding from any other side. There was history of constipation present on and off during this period, and there was no history of cold intolerance or weight gain. There was history. There was also history of passage of black-colored stool on the occasion, on 1 to 2 occasion, and there was history of boils present over the legs since past 2 years, which increased in severity since last 1 year, and which usually happens in summer only. And it used to relieved on oral medication in 5 to 6 days. There was history of pica, history of bleeding from any other site, warm passage or major surgical procedure in past. There was no history of fever, weight loss, chronic cough or hemoptysis. There was no history of localized lump, abdominal distension or bone pain. There was no history of yellowish discoloration of skin, eyes or high colored urine, and there was no history of blood transfusion in the past. There was no history of abnormal movement, altered sensorium, paucity of movement or poor school performance. There was no history of recurrent ear discharge, headache, recurrent respiratory tract infection, loose motion, vomiting, urinary complaints or oral ulcers. There was no history of abdominal pain or bilateral leg pain or cola colored urine passage in the morning. There was no history of facial puffiness, bilateral leg edema or increased awareness of heartbeat. There was also no history of drug intake for any chronic illness or prolonged medication. There was no history of radiation exposure. Also, there was no history of coughs or any contact with activity. There was no history of joint swelling or pain. There was no history of blindness or hearing problem.
So, you appear to have a very long negative history. Just could you elaborate why are you mentioning about the history of impairment of hearing and...
Sir, as from the history, it appears that child is having progressive pallor, and also he is having bleeding manifestations in the form of bluish discoloration over the skin. So we can assume that he is having anemia, and also he is having thrombocytopenia. So we can rule out the causes which can lead to thrombocytopenia and anemia. We can assume that if pancytopenia is there, so we should rule out these causes. So so in case of osteopetrosis,
How we came to know it is pancytopenia?
so if 2 cell lines are depressed,
By this history, we don't know that,
Sir,
in this?
sir, according to definition of pancytopenia, if there is depression of 2 cell lines out of 3 in peripheral smear, then we can call it as pancytopenia along with bone marrow hypoplasia. So, according to history, 2 cell lines are depressed, so we can rule out other causes of decrease in cell lines. So, here I got the history of blindness and hearing problem because of to rule out osteopetrosis, which involve blindness and hearing problem. Also, there is increased susceptibility to fractures, and also there is cranial nerve palsies and facial paralysis and some other problems associated with osteopetrosis.
Okay, so you have got a very elaborate list of negative history, and can any one of you, yes, you can tell why she was mentioning about hemoglobinuria, particularly the cola colored urine, what disease she is thinking of with that bilineal involvement, or clinical history which is suggesting there is anemia as well as thrombocytopenia, and she also mentioned about absence of hemoglobinuria. What do you mean by this? What she is thinking of? Pardon? Intravascular hemolysis, but what disorder she is thinking when she is thinking of the intravascular hemolysis in addition to these two things? Yes, so PNH is something which can have all these three symptoms, like there could be hemoglobinuria as well as there would be thrombocytopenia and right? So, any other thing in the history you would like to ask from her? She mentioned that there is no history of chronic drug intake. Anything else? Sapna? Okay, let us hear further on the history.
For all these above mentioned complaints, child was shown to some higher teaching center nearby the child, where he received multiple blood transfusion in form of PRBC and platelet, and he was later on worked up. On workup, he was told to have some hematological condition and counseled accordingly. During this period, child received multiple transfusion, and then before 2 months, child came to our hospital with complaints of red spots pinpoint all over the body for 1 day and easy fatigability and dizziness for 1 day, for which he was transfused with PRBC and platelet, and since then he is under follow-up.
So, you have, is this the whole history of present illness, or do you have something else to mention?
Sir, during this follow-up, he presented with complaints of fever and recurrent oral ulcers many times, and there was no history of other like ear discharge or urinary tract infection or cough coryza and fast breathing, and there was no history of drug intake early in the morning or overnight drug administration. And this blood transfusion rate, which was since 2 months, it was initially twice monthly. Now since 1 month it has increased to once per week. That
Okay,
is
so his transfusion requirement has gone up over the last 1 month or so.
yes, sir.
Right. All right. So, you mentioned that you were thinking of pancytopenia in this child right from the history itself. So, like one cause you mentioned is osteopetrosis, rather uncommon. The other came up here, PNH. Overall speaking, generally, what are the causes of pancytopenia?
So we can divide it in various categories, like one is hypoplastic diseases like acquired and congenital conditions. Other is nutritional like megaloblastic, and others are malignancy infiltration, which could be a malignant infiltration or some other infiltration. They can be in the form of acute lymphoblastic leukemia, acute myeloid leukemia, myelodysplastic syndrome, and HLH. And other non-malignant infiltration will include storage disorders and
All
And
right.
we can
So one large group is the bone marrow infiltration. So which may be because of the malignant diseases like leukemias of several types, or maybe the infiltration of the marrow by disseminated malignancy, right? The other you said is the hypoplastic marrow, and the third you said the nutritional megaloblastic anemia,
so,
and then infiltration with the other cells like the storage diseases,
Yes, sir.
etc. Okay, so by and large, this is the theoretical background, that these are the causes of pancytopenia. But if you look at what kind of cases that we see, can you enumerate some causes what we see commonly as the causes of pancytopenia?
So one of the most common cause of pancytopenia, which we usually see, is aplastic anemia, hyperplastic anemias, and megaloblastic anemias. Infectious causes like post-infectious, like viral infection, hepatitis B, and so others are immune causes, and
So
like
quite
parvovirus infection.
often, can you enumerate some infections which cause pancytopenia? Okay, one is that you are mentioning hepatitis B, C and HIV, parvovirus, all causing in some way the bone marrow suppression. Is that you want to say? Otherwise also there are some infections which are associated with pancytopenia, like they may not be having a very chronic course like this child has about 6 months, 7 months history, but when they present acutely they have pancytopenia.
Sir, so other like malaria,
Yes,
enteric
yes.
malaria.
So when we are discussing the causes of pancytopenia, even conditions like malaria, enteric fever, Kalazar, that is Kalazar is a very, where the Kalazar is seen more commonly in eastern part of the country. The pancytopenia, maybe they are seeing this Kalazar as the commonest cause of pancytopenia, right? So even tuberculosis can cause pancytopenia.
Infectious
How
mononucleosis.
tuberculosis can cause pancytopenia?
Sir, it can cause by infiltration in bone marrow, and thus this can cause pancytopenia.
Yes.
And sir,
Okay, so
and sir, one more important cause can be drug induced also, so which we usually use in our clinical setup, like sulfonamides and chloramphenicol and anti-epileptic drugs. So they can also cause pancytopenia.
so they can cause the bone marrow aplasia, you mean, is it?
So hypoplasia
Okay.
or suppression.
All right. So with this knowledge of the etiology of pancytopenia, let us see what is your what are your examination findings in this child.
Sir,
Is there anything significant in the past
sir,
history?
Past history, yes sir.
Yes.
Sir, not very significant, but just negative history.
Mhm.
Sir, child had febrile seizure at the age of 2.5 year, for which he was prescribed antipyretic drugs, but he was not given any chronic medication. Mother was not giving any anti-epileptic drug for febrile seizure, and there was no history of BT in past, yellowish discoloration of skin. That's it. And in family history, child is product of non-consanguineous marriage, and there was history of one abortion which was because of unplanned pregnancy, and there was no history of sibling loss, and there was no history of diabetes, hypothyroidism, mental retardation, epilepsy or malignancy in the family, and there was no history of blood transfusion in the family. And child studies in third class and was average in studies before the illness, but now he's not going school just because of the illness. Immunization history, child is immunized for the age, and in dietary history, child is basically vegetarian but occasionally have non-vegetarian diet, and he is taking age appropriate calories and protein, and he is lying in falling in socio-economic status of lower middle class. So in history, that's it.
Okay. So let us see the. Can you summarize the history? What all he has?
Sir, we have Mohit, 9-year-old male child. He presented with complaints of progressive pallor for 1.5 months, bluish purple spots all over the body for 1.5 months, and there was no history of any blood transfusion prior to that. There was no history of yellowish discoloration of skin, and there was no history of, there was no significant family history, there was no significant past history, and no history of chronic drug intake was there. And child is developmentally normal according to history, and immunized for age, and is taking age appropriate calories and protein.
And overall, you said that during this period of 2-3 months, the transfusion requirement
Yes,
seem
sir.
to have increased.
Yes, sir.
Okay. Okay. So let us see what are the examination findings in this child.
Child is average build, sitting comfortably and looks alert, with IV cannula in left cubital fossa. Vitals when I checked were 80, pulse rate was 80 per minute. In right radial artery it was regular, good volume, and with no radioradial or radiofemoral delay. And respiratory rate was 26 per minute, which was regular, thoraco-abdominal, with no use of accessory muscles, with no obvious breathing difficulty. BP was 102 by 72 millimeters of mercury in right arm in sitting position, and which was lying between examination finding.
You can demonstrate these findings.
Child is sitting comfortably in the chair, looks alert, and is average build, not thin build, and vitals are like pulse rate is around 72 per minute and regular, good volume, and coming on general physical examination, hairs are normal and normal in texture and color. Skull shape is normal, head size no obvious microcephaly or macrocephaly, and no facial no dysmorphism, no features of dysmorphism are there. Eyes are normal, no evidence of hypomelanosis, and nose is normal, no evidence of any facial dysmorphism, and there is no evidence of any nutritional deficiency, and there are some bluish purple spots which are present all over the body, over the arms, on the forearm and hands, and there are these are bluish purple spots.
Okay.
And also there are pinpoint pink rounded spots all over the body, also present. These are the spots. Petechial rashes. And child looks pale, although he received blood transfusion yesterday only. जी बाहर निकालो
So,
ऐसे हाथ दिखाओ।
what about his hands? Are they all normal?
Compare with the compare with your hand.
चाइल्ड लुक्स पेल सर पैलर थोड़ा सा है
Hmm.
Your hand. Keep your hand.
But he received blood transfusion,
Yesterday.
pack cell transfusion
हाँ, sir.
yesterday.
Yes,
Yes. Hmm.
and
Okay.
no visible congenital anomaly is there, and no visible localized lump or swelling, and no there was no hypopigmented or hyperpigmented areas or over the body, and मैं थोड़ा सा तुम्हारी शर्ट ऊपर कर लूँ, खड़े हो जाओ।
Where specifically you are looking for the skin lesions, and what lesions you were looking for?
Sir, we can look for cafe oli spots over the trunk and
Okay,
back.
capillary spots are seen in which condition? In association with the,
Fanconi.
all right, Fanconi's pancytopenia, and
And sir, we can also look for loosely reticulated lesions over the upper part of the neck and chest,
Yeah.
sir, which are specific for disc keratosis congenita.
all right.
So that we can rule out
disc
congenital
keratosis congenita would have a typical skin lesions.
loosely reticulated
Right.
lesions.
So that is over the face,
face, neck, and upper
and
part
upper
of the
part
trunk.
of the trunk, the back also and the front also,
Yes,
right?
sir.
What are the other changes that you see in disc keratosis congenita?
Sir, we can, sir, we have gray white hair and hypopigmented hair, and we can also check nails. Nail dystrophies are there.
Yeah, so nails.
The nails are normal.
Yes, dystrophy of the nails is there. Okay, and
And sir, we can also check in mouth leukoplakias.
Yeah.
It forms the triad of disc keratosis congenita.
All right.
Leukocutaneous triad.
you also mentioned there are no obvious congenital abnormalities. What abnormalities specifically you were looking for?
Sir, like in case of Fanconi's anemia, we will check for hypoplastic thumb or absent thumb, and like in case of Schaumann-Diamond syndrome, we will look for the thorax and flaring of ribs, so that we can make some clues about Schaumann-Diamond syndrome.
Okay, okay.
And sir, there is no.
So Fanconi's, you said the abnormalities of the thumb are most common, right? And is there something in the face and head size?
Yes, sir. In Fanconi's, usually about 30% of patients present with physical anomalies and hematological changes, and around 1/3 of patient does not present with physical anomalies. So they can be absolutely normal. But like in Fanconi's anemia, we have to look for certain changes and facies. In Fanconi's anemia, we have microcephaly, and we have abnormal eyes, like we have abnormal apicanthal folds, slanting fissure, and retrognathia, and short stature is also there in Fanconi's anemia, and
All right. So Fanconi anemia has lot of markers, but do you think that if the physical features are not present, we can exclude the diagnosis of
no, sir.
Fanconi's anemia?
Sir, no, sir. Actually, in 1/3 patients, they can
There are
be
no
absolutely
physical
normal.
findings. All right. So you looked for the findings of Fanconi's and some markers of disc keratosis congenita which are not there.
Yes, sir.
What specifically you look for which could be suggestive of megaloblastic anemia? Though he is a little older child, mostly megaloblastic is a condition that you see in under 5 children. What are
Yes.
the specific things that you look for megaloblastic anemia?
Sir, megaloblastic anemia, sir, acral hyperpigmentation is there, like knuckle hyperpigmentation we can specifically look for, and we can also
Can you show where exactly you look for? the
we
knuckle?
will look for knuckle hyperpigmentation here, over this part and this part, but
All
this
right.
is absolutely normal, no knuckle hyperpigmentation. And
Okay.
also we can look for other micronutrient deficiencies which are along with megaloblastic anemia can be there. So,
All right.
Like
sir, like hypopigmented hair can be
apart
there
from whatever
along with
usual deficiency or that
sir, vitamin A deficiency, sir, sir, keratosis can be there, and sir, bitoid spots or sir, xerostomia, and sir, chlosis can be there, and sir, dry skin, and sir, koilonychia can be there, and spoon-shaped nails can be there in iron deficiency anemia, and
Okay. So, in general physical examination, are there specific findings in this child?
sir, in this child, sir, in eyes there are now it is muddy discoloration over the cornea in the conjunctiva, but one day back it was conjunctival hemorrhage, which is now resolving. But here I cannot show conjunctival hemorrhage,
Okay.
and sir, facial features are normal, no dysmorphism,
Right.
and hair normal, and neck
What is his anthropometry like?
Sir, anthropometry, sir, he is lying at 25th centile. His height is lying on the 25th centile, which is normal for age,
Okay.
and weight is on the 50th centile, which is normal for age. And sir, BMI is on the, sir, it is also normal BMI according to age.
Okay, you have checked that.
Yes, sir.
Right.
So, sir, he is not of short stature or
All right.
malnourished, and so most of the features of congenital hypoplastic anemia we can rule out, but we cannot exactly rule out because we have to check for other tests, so that we can rule out Fanconi's anemia and other hypoplastic like chromosomal breakage study we can do.
To be seen?
Hmm?
Anything else need to be seen?
Uh,
Head-to-toe examination.
Yes, ma'am. Ma'am, we can check for genital organs because in many these congenital anemias, hypogonadism is there, and
Hypospadiasis.
hypospadiasis. Yes, ma'am.
Going beyond your hypoplastic conditions, as you discussed in the long list of pancytopenia, what else will you like to describe in general physical examination itself?
So general physical examination, we can look for icterus so that we can rule out other causes like viral hepatitis and malaria or any intravascular hemorrhage.
That would be with the acute history.
Yes, sir.
But if say subacute history or slightly longish history, what other features you said you were thinking in the differential, talking of differential diagnosis, the lymphoretical malignancy, etc. For
Yes, sir.
that, what specific
Yes,
things
sir.
you will look
So
for?
localized swelling we can look for like lymphadenopathy, but this child is not having
Any
lymphadenopathy.
lymphadenopathy?
Yes, sir.
Okay. Anything else?
And sir, sir, any testicular mass which
All
we
right.
can use in
Yeah.
genital
Anything else?
examination,
Yes.
and so localized lump like abdominal malignancy.
No, that is the systemic
exam.
examination.
Okay.
Bone pain, sternal tenderness.
Yeah.
Sternal
What
tenderness,
about the bone tenderness or bone
Yes.
pains, or
Yes, sir.
sometimes even joint swelling is there in
Joint swelling.
leukemics?
Yes,
Okay.
sir. Yes, sir.
Yeah.
in the history it was there, but you have to examine that also.
Yes, sir.
Hmm.
And sir, also we can look whether child is comfortable or breathing normally or not, so that we can check.
Yeah,
for
that
acute
your
condition.
vitals will tell you. What about is there any, maybe you are dealing with some lymphoretical malignancy and the most of the lymph node enlargement is just intrathoracic, the peripheral lymph nodes are not enlarged.
Yes,
Okay.
sir. Yes, sir.
Hmm. But will that have some findings over the face also?
Yes, sir. Child will have, sir, suffusion of face, and will not look comfortable, and will
What
and
will happen to the
neck veins
what will
be
happen to the
dilated.
venous drainage
So
of
neck
the
veins will be dilated,
yeah?
and
So They would be prominent.
Yes, sir. Prominent.
Okay.
Will be
Sir,
regular venous pulse. Pulse will not be there, but it will.
it will looks pulsating.
Okay. So is there anything else in the general physical examination, or
No, sir.
we can quickly go to systemic examination?
Sir, that's all in general examination.
Okay.
Sir, sir, should I start with anthropometry? So anthro I already told.
Yeah.
And on coming to systemic examination, on per abdominal examination, sir,
Hmm.
so should I demonstrate or
You
should I
can
tell?
you can make him stand up and see.
खड़े हो जाओ.
कि वहाँ से प्रोजेक्ट कर सकते हैं क्या, उस पर लिटाएं अगर बच्चे को तो
कर सकते हैं.
नहीं,
यहाँ पर
यहाँ से ही बता दीजिए. आर देयर पॉजिटिव फाइंडिंग्स?
No, sir.
So,
no positive findings.
Yeah, ठीक है.
Sir-
That's fine. There is nothing, no specific finding to be shown. You
Yes,
can
sir.
just describe
Sir,
your observations.
Abdomen was not distended and all quadrants moving well with respiration. There was no obvious lump or swelling, and on palpation there was abdomen was soft and non-tender, and there was no hepatomegaly or splenomegaly or any localized lump, and hernial sites were free, and no free fluid was there, and note was tympanic, and no bruit, and so that's it on abdominal examination. No dilated veins.
So, when you are looking at the abdomen in a child like this, you have described the absence of enlargement of liver and spleen. Any other organ you would like to look for? There is no lump also, which means maybe you are looking for lymph nodes or any other organ.
So a renal lump we can
Renal
look
lump, right. So, what is the significance of renal lump in such a child?
for. Sir, the child with pancytopenia, if we are considering, if he present with renal lump, we can think of infiltration in kidneys, or we can also think of some other malignancy like lymphoma and leukemic infiltration, and
Anything in relation to your congenital causes that you were describing? Anyone else?
so horseshoe kidney,
Yeah, there are renal abnormalities
ectopic kidney, horseshoe.
in Fanconi's anemia. So, and if there are congenital abnormalities, there might be enlargement of kidney because of hydronephrosis
Yes, sir.
associated
Yes,
with
sir.
that, right? So, or it may be ectopic, so maybe the kidneys are palpable.
Yes, sir.
Okay.
And
What about other systems?
so they are absolutely normal, no positive findings.
when anemia is there, you should look for JVP anemia, whether it is a large
Yes, sir.
tile.
Sir, when I examined, then also child was sitting comfortably and was not having any breathlessness, and JVP was normal, and now also after transfusion child looks normal only, and JVP, sir, would
Okay. So, now with your physical findings, and we discussed a lot about the etiology of pancytopenia. What is the likely cause out of all this probable diagnosis that you will think of?
Sir, according to history and examination, sir, hypoplastic or aplastic anemias may be most likely acquired will be the most common differential diagnosis, will be the first differential diagnosis.
Okay.
And sir, we can
So,
ask,
why do you say acquired? Why not the congenital or hereditary?
sir, as from the history and examination and general physical examination and systemic examination, there were absence of features which can point towards congenital anemias and pancytopenias. Like we already discussed about Fanconi's and dyskeratosis congenita, Sherman diamond, and absent radius syndrome, and sir other anomalies.
What about age and the hereditary familial causes of congenital causes of pancytopenia? Do they present at this age? You said they are congenital. Do they present at this age or earlier or later?
So, like in case of Fanconi's anemia, it presents usually after 3 to 4 years, but it can present before 10 also. It is the range of congenital Fanconi's anemia.
Okay, so congenital Fanconi's anemia can well present at this age, right?
sir.
Though it is congenital, but quite a lot of cases present after initial 4 to 5 years of age, right? Mostly they present later.
Yes, sir.
Okay. What about dyskeratosis congenita? When do they present?
So, similar age, sir.
Even later.
Even later.
Later, yeah. About 10 years, beyond 10 years mostly. Okay.
And so, like in osteogenesis imperfecta, so there are two forms: autosomal recessive and dominant. So, one form.
Osteogenesis imperfecta, or you are confusing with
Sir, sorry.
osteopetrosis?
Osteopetrosis, sir.
Ah.
Sorry. Sir, they can also present the other form, that is autosomal dominant, which is milder form as compared to
Tarda.
yes, sir.
Right. So
Tarda
that can present later,
Later.
at this age. Yeah. And some children do present very early in
What
life.
about the organomegaly?
Yes, sir. There is organomegaly because of extra hematopoiesis, extramedullary hematopoiesis.
So that you would have picked up
Yes,
on
sir.
your
Yes, sir.
examination itself.
Yes, sir.
Okay.
And so it can also osteopetrosis also have blue sclera in patients. So we can find this in
So
genetic
your first
examination.
diagnosis would be bone marrow failure
Yes, sir.
syndrome,
Bone marrow failure
and
syndrome.
likely acquired, that you want
Yes,
to
sir.
say.
Yes, sir.
Okay. But I think you are not trying to say that congenital can be totally excluded.
Yes, sir. We cannot totally exclude
Right.
congenital.
Okay. So any other possibility, or you will stick to this diagnosis and investigate?
Sir, with this long history, we cannot consider differential diagnosis of leukemias or malignancy.
All right. So had he come with a history of 15 days or so,
Then we can
right,
definitely
you could
consider.
have thought of a subleukemic leukemia.
Yes,
Okay.
sir.
And this is now the history is about 7.5 months.
Yes, sir.
So it's unlikely that leukemia would go on and without liver spleen enlargement till this age.
Yes, sir.
Any other possibility?
Sir, megaloblastic also we can keep, but it will be less likely because organomegaly will be there, and sir, course will be shorter as compared to this 7.5 months. And so other features like knuckle pigmentation and cognitive decline can be there in this megaloblastic anemia.
What about undernutrition?
Yes, sir, undernutrition.
Right. So absence of undernutrition, absence of knuckle hyperpigmentation, and what is the common age when you see mostly the megaloblastic anemia? Anyone from audience here? Huh?
And infancy.
Megaloblastic anemia after 10 years. Mostly you see infants and young children. They are mostly having this problem here in our hospital that we see mostly. So according to our profile, he appears slightly late for megaloblastic anemia, and as we discussed, the absence of malnutrition, or rather only mild malnutrition is there. The knuckle hyperpigmentation is not there, which is quite commonly seen. So that is less likely diagnosis.
Yes,
Anything
sir.
else? Or you would go for the other investigations after the baseline workup?
Sir, other causes also we can rule out from history and examination. Like there was no history of drug intake, so any toxin or drug or radiation exposure will not lead to this kind of picture. And if infectious causes we are looking for, then malaria or tuberculosis or enteric fever we can work up, but they will have short history as compared to
Yeah,
this.
malaria and enteric fever kind of type of possibilities
not
are
there.
not there
Yes,
here.
sir.
I mean, that's a short-lived
Yes, sir.
condition. They would either deteriorate and will have other findings, and malaria and enteric both will have some degree of
Fever
organomegaly.
or
Okay?
organomegaly.
So that is probably out here.
Yes, sir.
Yeah. So those infections are very unlikely here.
And sir,
Infections causing bone marrow aplasia, that possibility is still there, as you said, acquired. That we can discuss later on. What could be the causes of acquired that you will look for here? Okay, but so what investigations will you order initially?
sir, first of all, with history and examination, what we thought of, like there is suppression of cell lines, suppression of two cell lines. So first of all we have to establish that there is cytopenias. So we will order complete blood count, complete hemogram, and in that we will look for hemoglobin and total leukocyte count, absolute neutrophil count, platelet, retic count, MCV, and other parameters like peripheral smear. We have to see whether there is pancytopenia or not. And
So what do you expect in bone marrow failure syndromes in all these parameters? What all would be there?
sir, in bone marrow failure syndrome, there will be depression of cell lines, like there will be anemia and thrombocytopenia, or there can be neutropenia or leukopenia. So it is not definitely there that all cell lines will be depressed. It can be two or it can be one also. Later on they can appear that other cell line will also depress.
So in this child,
time.
is this child the symptoms themselves are suggestive of two or maybe even three cell lines suppression,
Yes, sir. Yes,
isn't
sir.
it?
Yes, sir.
So what do you expect in this child's reports?
Sir, in this child's reports, there will be anemia and thrombocytopenia and leukopenia, neutropenia will be there, because child since last 1 month he was coming with fever and oral ulcers. So he's giving history of recurrent infection since last 1 month,
Okay.
not since 6 months.
Okay, so even if he had started with bicytopenia, that is anemia and thrombocytopenia, now you think
Yes, sir.
he might have
Developed
neutropenia as well.
leukopenia
All
as well.
right. So what are other things in the initial workup will tell you that this is bone marrow failure syndrome? What other things do you look for?
Sir, we can check for MCV.
Yeah.
Sir, in case of bone marrow failure syndrome, it will be raised, and it can be normal also, but will not
Okay,
be.
it will be.
Yes.
Why it is
Why MCB is increased in bone marrow failure syndromes?
Sir, it could be because of stress hematopoiesis.
Stress hematopoiesis leads to some degree of
Macrocytosis.
macrocytosis.
Yes, sir.
All right. So that is one. And are there any other condition in which MCB is increased and there is pancytopenia of the whole list that we discussed? Megaloblastic. All right. Anything else?
Sir, other anemias like diamond blackfin syndrome.
Well, MCB, though that is a single cytopenia, but MCB is increased in that.
And
All
sir,
right.
in case of any drug ingestion or immunosuppressive therapy also, they can have pancytopenia and MCV raised,
Like.
like methotrexate or cyclophosphamide or
Okay,
other.
so the antifolate therapy that would
Yes,
cause the same mechanism
Picture.
by which the megaloblastic anemia
So
occurs.
it is
in
the
this.
maturational arrest. है
Any
ना?
other
So it is
condition?
more.
anything else?
in which MCV is raised, and maybe I can give you a hint that bone marrow is hyperplastic,
Anyone?
more of condition of adults.
PNH.
Hmm? Myelodysplastic
MDS.
syndrome.
Vitamin D,
Myelodysplastic
vitamin D
MDS
that.
is
Myelodysplastic syndrome
Myelodysplastic.
will have the increased MCV. Okay,
Yes, sir.
but myelodysplastic syndrome mostly will have the organomegaly,
Yes, sir.
and the pancytopenia is
Yes,
there,
sir.
and
Yes, sir.
the MCV is there. All right. So one is MCV increase, which could give you a clue that this might be let's say aplastic anemia. And what else? What about the reticulocyte count?
Yes, sir. Reticulocyte count in case of bone marrow failure syndrome will be less.
Okay, but that would be decreased in all infiltrations. And are there any conditions in which there is pancytopenia, but the retic count is increased?
Yes, sir.
Huh? Can you think of?
Sir, I didn't have no
Huh?
PNH.
PNH actually is a disease which has different manifestations. Like if you say hemolysis leading to increased retic count, but then the PNH pancytopenia occurs when there is aplasia, isn't it? All right. Are there conditions in which peripheral destruction is occurring and cytopenias are occurring?
Yes, sir. Like in hypersplenism.
Okay, one is hyperinsulinism when pancytopenia is there and retic count would be increased.
Yes,
Any
sir.
other?
And sir, Evans syndrome.
Evans syndrome, what is that?
So autoimmune thrombocyte.
Immune hemolytic anemia with immune thrombocytopenia, right? So rarely that Evans syndrome can be associated with pancytopenia.
Yes,
Right?
sir.
Even the TLC and neutrophil count also can be low as a result of peripheral destruction. So the retic count would be increased in that situation. All right. So do we have the reports on this child? The initial reports? Yes.
The child presented to us with a hemoglobin of 5.3, a total leukocyte count of 1970, a platelet count of 2000, absolute neutrophil count of 420, absolute reticulocyte count of 9900, and a corrected reticulocyte count of 0.39%, an MCV of 93 femtoliter, MCH of 29.3, MCHC of 34.7.
Do you have peripheral smear report?
Yes.
Okay.
The peripheral smear showed leukopenia and thrombocytopenia. RBCs were predominantly normocytic and normochromic. The impression was suggested to be that of pancytopenia. The bone marrow biopsy.
Okay, we can discuss that later. So this report shows you leukopenia, anemia and thrombocytopenia. There is reticulocytopenia also,
Yes.
only 9900 you said. What about MCV? This is normal for this age or raised, or how do you look at it?
It is normal for the age.
93 you said.
Yes, sir.
Is it raised? Yeah, for a how do you look at the MCV? How do you say that it is high? What is the cutoff?
formula.
84 plus 0.6.
We
into
mostly
age.
use that formula. Anybody who knows?
84 plus 0.6
Huh?
into age.
Pardon?
84 plus 0.6 into age.
Yeah, mostly between the ages of 2 to 10 years, 84 plus 0.6 into age in years, right? So for a child of 10 years, the cutoff would be 90, right? And there is no harm in having a lower cutoff of MCV to call it macrocytic, because that would be including more cases, and then you can look for the definitive cause of the macrocytosis. So this child is 8 years old and 9 years. So he would by that count it would be less than 90, but he has 93. So it is higher than normal for his age. For the adults, you have cutoff of 98 and 100 and sometimes even 102 people use to call it the macrocytosis. But for this child, 93 is high. Okay. So macrocytosis is there, and then what about the neutrophil count? Can you tell us?
So absolute neutrophil count was 420, sir.
420, and we have a regenerative pancytopenia, right? So next investigation.
Sir, by this picture we can do bone marrow biopsy for this child and bone marrow aspiration examination, and we can also order for some viral markers like hepatitis B, anti-HCV and anti-HAV, and also human immunodeficiency virus, and we can also order, sir, I am telling the complete panel of evaluation of pancytopenia, not according to this child only. Sir, इसमें तो BMB is relevant.
Bone marrow biopsy would be the investigation which will confirm the
Yes, sir.
diagnosis.
Yes, sir.
Okay, and then you are trying to look at the etiology,
cause.
is
Yes,
it?
sir. Yes, sir.
right. Okay, for that you wanted to see the viruses.
Yes, sir. And sir, we can also, we should also, before giving any therapy for this type of anemia, we should also rule out congenital anemias. So we will order for chromosomal fragility also. So
Chromosomal breakage,
breakage
studies. How do you
study.
do that?
Sir, the cells of the patients will be grown with some agents like mitomycin C and epoxybutane. They will increase the fragility of these cells. The cells which are
the
normal.
chromosomes, not the cells.
So chromosomes, and these cells which are normal will not break under these stress condition,
Yeah.
but the cells of and chromosomes of patients with Fanconi's anemia, they have increased chromosomal breakage sensitivity. So it will break under mitomycin C or epoxybutane. So
Okay.
it will have increased fragility because their genome is not very stable. And
All right. So you will order for the viral infections that you mentioned, and you will also ask for the chromosomal breakage studies, right? Do we have results of these bone marrow biopsy and other? Yes.
Viral markers for hepatitis were non-reactive, HIV was non-reactive, Cox workup was normal, coagulation profile was normal, serum bill was 0.6, KFT was normal, chromosomal breakage study was normal. Bone marrow biopsy showed bony trabecular enclosing marrow showing no particles and hypocellular for age. There were presence of few lymphocytes and plasma cells and occasional erythroid and myeloid cells. No megakaryocytes were seen. A provisional impression of hypocellular marrow was given.
Okay. So that confirms the diagnosis of aplastic anemia, and it is acquired,
yes, sir.
right?
Yes, sir.
So in acquired, whatever causes that we have looked for, other than that, what do we label this as? Idiopathic?
Yes, sir. But before labeling it as idiopathic, we can order some more investigation so that we can rule out the etiology. So,
Like?
like parvovirus, we can order.
Okay, parvovirus B19. Does that cause pancytopenia in?
Not in this age group.
No. What is the? Can anybody describe the pancytopenia associated with parvovirus infection? Can you speak in the mic? Come here and speak in the mic.
So pancytopenia due to parvovirus B19 mostly it will cause in case of child having hereditary spherocytosis or sickle cell anemia.
Yeah,
Or
typically described as children with pre-existing hematological disorders, particularly the hemolytic anemias. They have a plastic crisis, and that is because of parvovirus B19 infection. And what is the course? Does it last that long, or
so it will persist transient only.
mostly transient, but very rarely it can persist? So, parvovirus B19 is something is very less likely, but then there are certain people who tend to do this investigation as well in these patients. Okay.
And sir, also
So-
we can do flow cytometry for paroxysmal nocturnal hemoglobinuria for DAF proteins and MERL like CD55 and
Okay.
CD59. And sir, so
So-
we can rule out PNH also.
Okay, right. So, PNH workup is required. What is the incidence of PNH across the pediatric age group? Any idea? It's quite less.
Yes sir.
There is
Very
not
rare.
much.
Sir, rare.
There is not much data from India in pediatric age group, but occasional case reports are there. So, PNH workup mostly the centers who are doing the aplastic anemia management in our country, they are doing PNH workup also in these children. So, that completes the workup, or you
No,
still
sir,
want to do
we-
some more?
Sir, we before giving therapy, we should rule out congenital.
Even more some congenital disorders. Okay.
Sir, they will not respond to novel therapy, so we should rule out.
Okay.
Sir,
So-
we can do HbF levels also. Sir, in these anemias, they will be raised.
Okay. Fetal hemoglobin level.
Yes, sir.
In which conditions they would be elevated?
Sir, Fanconi's anemia and diamond blackfin and
See, diamond blackfan is out since there is thrombocytopenia and other things also.
Yes, sir.
Fanconi's, you have done the
Discarrot-
chromosomal breakage studies.
Schaumann diamond.
They
Dyskeratosis
will
congenita.
have Schwarzman diamond, they will have some more, like, alright, so let us look at the list of the familial or hereditary or the congenital causes of pancytopenia or a bone marrow aplasia. What are those? You said these 2-3 conditions, Fanconi's, dyskeratosis congenita, what else?
Sir, A megakaryocytic thrombocytopenia
Okay.
and sir, absent radius thrombocytopenia with absent radius syndrome and sir,
They will be very, very rare. TAR, I don't know if progresses to pancytopenia.
sir rare,
In that-
very rare.
The megakaryocytic sometimes does, and that also goes on to develop pancytopenia sometimes. What else?
Dubovitz syndrome, Sickle syndrome,
Yeah.
and sir, hair dysplasia, hair bone dysplasia, cartilage
Cartilage hair
dysplasia.
dysplasia.
And so
Okay.
Pearson syndrome sometimes can lead.
Okay. So they are very rare conditions, and
Very rare.
there would be some markers, and you can't order for all
Yes, sir.
investigations.
And sir, vitamin B12 folic acid we can also order.
You can see the changes in marrow.
But if clinical
Actually-
features suggestive.
Actually, I can tell you, if you read the Western books, and in general they would write that in cases with pancytopenia you should do these levels. But B12 folate deficiency would lead to a pancytopenia, the marrow would be hyperplastic.
Yes, sir.
The marrow
Hyperplastic.
would exclude that diagnosis, isn't
Yes,
it?
sir.
So there is no point of getting these investigations done. They are not going to be very useful. Okay. So
And sir, before starting therapy, we can rule out tuberculosis from chest X-ray and
that
Montus
has been
and
done already.
Yes,
in this
sir.
child. Yes. Okay. Because you are going to give some immunosuppressive therapy. Okay.
it is one of the part of therapy alternative.
So, can we have a short, Dr. Piali can present briefly the pancytopenia and its causes and approach, and then we can come back to the case and discuss how we will manage such a child.
Okay. So now defining pancytopenia, there is a decrease in at least 2 of the 3 cell lines. Cutoff used in some of the studies are HP less than 10, ANC less than 1500 and platelet count of less than 1 lakh. International agranulocytosis and aplastic anemia study has given cutoffs as HP lower than normal for age, ANC less than 1500 and with a platelet count of less than 50,000.
So, for the cutoffs for the leukocyte, it's better to have a cutoff of neutrophils rather than the TLC, okay? Because bone marrow activity is better reflected by the neutrophil count rather than the total leukocyte count, okay?
So as Dr. Preetham has already mentioned, there can be picture of hypocellular bone marrow, there can be bone marrow infiltration or normal cellular marrow. So she has already mentioned the causes, like in hypocellular we can again HLH and infections which we have already discussed, enteric malaria, mycobacteria or brucellosis kala azar. So this is a study in Journal of Tropical Pediatrics where megaloblastic anemia was the most important cause of pancytopenia, followed by acute leukemias, aplastic anemia, infections and then the miscellaneous causes.
So, the important point to take home from this data is that nearly 20% of the cases the causes are due to infections, around 30% were from the megaloblastic. So, the so-called sinister causes, the aplastic and leukemics, they are not the only causes of pancytopenia. There are quite a few things which are very easily treatable. Promptly you diagnose and you can take care of the cause of pancytopenia. Like megaloblastic anemia, pancytopenia will respond very quickly to the appropriate treatment.
So how do you approach a child with pancytopenia? After a detailed history, physical examinations, we ordered investigations.
We can
In history,
quickly
we can
show some
we can
findings,
just
yeah.
So there's a picture of pallor. One has to compare for the pallor. This is knuckle hyperpigmentation. The next picture, is it visible? Focus. Moving on to in physical examination, bleeding manifestations. We can see petechiae, subconjunctival hemorrhages. We can look for lymphadenopathy for leukemia, disseminated tuberculosis, infectious mononucleus or LCH. Bone pain and tenderness has to be looked for. These are some congenital malformations like in Fanconi, she mentioned peculiar bud facies, flat head, microcephaly, frontal bossing, short or low hairline, web neck. So basically patients that resemble each other more than their family member. Preetham, this
There are two pictures. One is this child from which we admitted about 10 years back, and this is the picture downloaded from internet. And they resemble each other quite a lot, isn't it? They both are Fanconi's.
So again, there is some skeletal malformation, radial anomalies, skin hyperpigmentation, capsular spot and hypovitiligo.
This hand, the thumb abnormalities on the left side is the same child that showed in the previous slide. admitted at our place.
So, what's this?
Next picture, it would be better clear. Huh?
So, nail dystrophy, and then if you just correlate, what was this? Reticular pattern which she mentioned in dyskeratosis congenita. Moving on to the examination with hepatosplenomegaly, you should think of acute leukemia, storage diseases, disseminated TB, LCH, osteopetrosis, myelofibrosis with myeloid metaplasia, Kala Azar, malaria and enteric. But 10% cases of aplastic anemia and megaloblastic anemia can also have mild splenomegaly. As for investigations, CBC, she has
We can
mentioned,
skip
we can
this,
skip
yeah.
this one, yes sir, definitely. So, smear examination will also provide you information regarding malarial parasites, blast, dysplastic changes, leukoerythroblastic pictures in case of myelofibrosis, infections, immune cytopenias. This is the same classification: hypocellular marrow, normocellular and infiltrative bone marrow. So, we are just skipping. Coming to aplastic anemia, we have mentioned regarding the acquired causes, and these are the inherited bone marrow failure syndrome: Fanconi, dyskeratosis congenita, Schwammen-Diamond, reticular dysgenesis, A megakaryocytic thrombocytopenia, familial aplastic anemia, non-hematological syndrome, Down syndrome, Duovich and sickle. So, one has to exclude constitutional aplastic anemia before moving on to therapy. So, breakage studies by mitomycin C or diepoxybutane. So, they are prone to get breakage when stress induced breakage is there. Moving before therapy, one has to assign severity
Let
for
us
the disease.
see,
So,
Preetham will tell us how she is going to define the block it. Yes.
Okay.
So, coming to the management of this child, we are planning to label it as acquired. Okay. So, where do we go from here?
After establishing the diagnosis of aplastic anemia, we should first categorize whether it is moderate aplastic anemia, severe aplastic anemia or a very severe aplastic anemia. According to this classification only, management will differ. So, in severe aplastic anemia, we will have to check for cellularity of the marrow. It should be less than 25%, and if it is between 25 to 50%, then marrow should be less than 30% regenerative marrow. And along with this hypocellular marrow, we should have two of the following which I will be describing. ANC count should be less than 500, and hemoglobin should be less than 10, and reticulocyte count should be,
Hemoglobin is not a criteria.
sorry, so platelet count should be
For-
less than 20,000.
It's easy, don't get confused. It is easy to remember. For the neutrophil, you have a cutoff of 500. For red cell, you have the cutoff of reticulocyte count, isn't it? So hemoglobin is nowhere there.
Yes, sir.
Okay. Yeah.
Sir, neutrophil should be less than 500 per cubic millimeters, and platelet should be less than 20,000 per cubic millimeters, and reticulocyte count should be less than 20,000, or percent should be less than 1%.
Corrected
Of the
retic count of
corrected-
less than 1% or less than 20,000 if you are doing the absolute reticulocyte count. Okay.
And
Yeah.
out of these three, if two are positive, then we can label as severe aplastic anemia. And in case of very severe aplastic anemia, if neutrophil count is less than 200 per cubic millimeter, then we will call it as very severe aplastic anemia. And
Alright.
and the anemias which will not fulfill these criteria will be labeled as moderate aplastic anemia.
Okay. So we had some 9,000 retic count.
Yes, sir.
Huh? And what was the platelet count?
Sir, it was
Huh?
severity for this one?
Platelet count? 2,000.
2,000.
Okay.
So platelet count of 2000, absolute neutrophil count of 420, and retic count of 0.3% on and absolute retic count of 9,900.
Okay, so retic and platelet both are less than the cutoff. Neutrophil is also
420.
less than cutoff,
Yes,
but not too bad, right? So you would what about the transfusion dependence or not? Do you go just by the cutoffs or you look at the transfusion dependence also?
Sir, transfusion dependence
Yeah,
also.
the
we should
patient has to be transfusion dependent and these criteria, marrow as well as the peripheral blood. Mostly with these findings the patient would be transfusion dependent, isn't it? So you would label it as severe or very severe?
know. So severe aplastic.
Severe aplastic anemia. All right. So what do you advise the family?
Sir, first of all, we have to counsel the family about the hematological condition, that it is there are two treatment options, but the treatment of choice is bone marrow transplantation. So if they can afford, it will have success rate of around 80 to 90%.
So who gives the bone marrow? You will give? Huh?
Sir,
Where the marrow will come?
sir, they should have matched sibling donor.
Yeah, so complete statement should be the allogenic bone marrow transplant from a matched sibling donor is the first line treatment, isn't it? There are two things. One, the matched sibling donor has to be there. That is the important thing for the bone marrow transplant to be taken up as the first option. Okay. So that is one thing, and you have to see about the family, right? And what is the other treatment option?
Sir, usually in our setup, parents cannot afford this treatment. So the alternative treatment can be immune suppressive therapy. So in form of one drug or combination drug, which will also have success rate of around 70 to 80%.
Okay. So what do you mean, one drug or two drug? What do you mean by that?
Sir, it was according to some trials that if we
Which
usually,
drugs?
sir, it is anti-thymocyte globulin along with cyclosporin.
Okay. So what is the standard recommendation? Do we give one drug or do we give both the drugs?
Sir, if we use one drug alone, then success rate will be less as compared to combination. So now it is recommended that anti-thymocyte globulin along with cyclosporin should be given.
Yeah, so that is the standard management now. Bone marrow transplantation, if not available, then intensive immunosuppressive therapy using these two drugs. Okay. So as you rightly said, single drug use has lower response rates, and that is why in the beginning itself you give both the drugs. Okay. So have we talked to this family about the transplant? They are looking at this option. He has a sibling. Okay. So just in case they are not able to manage, either the sibling is not matched or whatever, the finances are not there. So how will you give the immunosuppressive therapy? What do you do?
Sir, there are certain prerequisites for immunosuppressive therapy. First of all, we should build up the platelet count to more than 30,000. So we will arrange for single donor plasma so that it can be raised to some normal level. It could be maintained for 5 to 6 days, and the child should be infection free. So we have to wait if the child is in some infectious phase, and so then we will give 2 days of antibiotic prior to giving anti-thymocyte globulin, and as anti-thymocyte globulin will result in severe hypersensitivity reaction. So first of all, we will give some micro dose of this
Test dose.
test dose.
All
Sir,
right,
test dose, so that we can check for the hypersensitivity. And then we will give ATG, and it will be given for over 5 days along with corticosteroid, that is prednisolone, so that we can reduce or we can decrease the side effects like serum sickness, which is mostly associated with antithymocyte globulin. And along with that, we can start after few days of antithymocyte globulin cyclosporin also. So it will be a combination treatment, and it will result in greater response rate. And it will be given over 5 days with the dose of 40
Okay,
mg.
so you give 5 days of ATG, and you do a test dose and pre-medicate with corticosteroids, and then after a few days you start the serum sickness preventive dose of corticosteroids, right? So that is how it is, and then you are after a week or so, you can simultaneously start the cyclosporin. Okay, so that will give you. In how much time do you think that the child would respond to this treatment?
Sir, before labeling as non-responsive, we should wait for at least 6 months, 4 to 6 months.
Okay, so mostly that 4 to 6 months is the time when you expect the response. And how do you come to know that the child is responding?
Sir, for response, we will again check for complete blood count, and child should be transfusion free.
Yeah,
Should
and the
not be
need for transfusion keeps coming
Decrease.
down
Yes,
gradually,
sir.
and they remain infection free, the bleedings don't occur, and that's the way it is. And after on your assessment, you
for complete
what is the first which is the first line to improve? First of the yeah, retic count comes up first, and if you are looking at retic count every week or so, or maybe this would be reflected in the MCV also. The MCV will start increasing. The macrocytosis on the smear, that would be the sign of infection. So
And sir, before labeling it as non-responsive, we should wait for at least 9 to 12 months, and we will see. And if there is some response, then we can repeat the dose, second dose or third dose, depending upon the response. And sir, response could be complete response or partial response.
actually, most of the recommendations are that initial ATG that you use is the equine ATG. Okay, but if you have to use repeat, that is the refractory to this first line. So the Western literature mostly would write that if there is no response to immunosuppressive therapy, which you gave because the allogenic matched sibling donor transplant was not available. So in that case, after the failure of IST, you think of transplant from other sources. So matched unrelated or haploidentical. Those are the options available. But in our country, what we do is, if the transplant is not a possibility, so it's unlikely that matched unrelated would be even more costly. So more expensive to afford. So we go for the second course, and for second courses, whenever are given for refractory to first course, they should be ideally by rabbit ATG, not by the equine. But if the again rabbit is little more expensive, so we will end up giving mostly the equine itself as the second course also. That can be used, but better is to give the rabbit one. Okay, so that is how it is. The response rates across the bird literature is this much. You said about 60 to 70%.
Yes, sir.
In India, most of the data is about 40 to 50%, except one series where it was about 80-85%. Most literature from India shows only this much response, only 45 to 50%. patients responded. But in the first place, why the immunosuppressive therapy? How does it work?
Sir, sir, I have somewhere, sir, it is like bone marrow suppression can be defined by two theories, seed theory and some, sir.
Seed theory. So if the crop is not occurring, either the seed is bad or the soil is bad, isn't it? But the point is, in both ways, it is the whether it is seed or the soil, the marrow or the stem cell, whatever is not good, of good quality, it is immune mediated injury.
Yes, sir, immune
Right?
mediated.
Mostly it is currently what is believed, is it seed or is it the soil? What is bad in aplastic anemia? Huh?
Sir, both theories. are
Both
valid.
theories are there, but mostly it is believed that it is the stem cell which is damaged, and that damage is because of the immune mediated mechanisms. So you take care of that by immunosuppressive therapy,
Yes,
and
sir.
that is how it helps.
And sir, other drugs we can also use, but they are less effective.
Okay,
Like,
so that's the specific therapy, the ATG or the transplant if they can afford. What about supportive therapy?
sir,
What do they need?
sir,
What level of hemoglobin you would maintain?
Sir, in A plastics, sir, we will maintain around 6 or 7. Sir, below 6 only we will give transfusion.
Mm-hmm.
And sir, platelet count we will maintain around 10,000, and below this we will give platelets.
Why
If
you are not taking more than 10?
sir, 5 to 10.
Why you are not taking more than 10? 6 to 7?
Sir, as they are chronically cell depleted, so they will, sir, they will adapt to this. So if less platelet count is there, they will not bleed.
Hemoglobin,
So hemoglobin.
you are taking 7, not the 10. Like other conditions, we are taking more than 10 for the growth and development.
Yes,
We are
sir.
taking
Why? Like in thalassemia, you want to keep a hemoglobin of about 9.5 to 10, isn't it? And on that you transfuse to build it to 13 to 14. Here you say that you are keeping it at 6 to 7. Why? Huh? Can anybody think of? Surya? Yeah, there would be stimulus to the marrow by keeping a lower hemoglobin. Okay, some hypoxia leading to whatever. How does that stimulate? There would be more erythropoietin drive. It's likely, right? So at least that will help the marrow recovery. Okay. But we tend to maintain little higher in the initial, particularly when the children are having any fever, they are febrile, you keep little higher, and after that, once they are stabilized, then you can keep this 6 to 7 and 10 of platelets, right? But certainly the platelet requirement would be more when there are infections, you would tend to keep it slightly higher. Okay. So it's like that. Okay, we can quickly have a look at how do they BMT and intensive immunosuppressive therapy, how do they compare, Dr. Piali?
So, in therapy, we have BMT or intensive immunosuppressive therapy as option along with supportive care. So, BMT is the treatment of choice. Matched sibling donor is the first line of treatment. Further improvements have been achieved in BMT with improvement of preparatory regimen, improved GVHD prophylaxis and supportive care. Most patients have normal
Your
growth.
mic is not working, it seems.
So BMT is the treatment of choice and matched sibling donor is the first line of therapy. Further improvement has been achieved in bone marrow transplant by improving the preparatory regimen, improved GVHD prophylaxis, improved supportive care. Most patients have normal growth, they have already attained the predicted height and have preserved fertility. But the problem is the lack of expertise, lack of finances and lack of matched sibling donor. So we'll end up giving immunosuppressive therapy. So as she has already described the seed and soil theory. Seed is the pluripotent stem cell and soil is the microenvironment of the bone marrow. So the defect can be either in the bone marrow stem cell or the stromal cells. They are all in seed theory, immunologically mediated damage can be there, or after exposure to antigen cells, cytokines of the immune system, or there could be a direct stem cell damage by irradiation, drugs and chemicals. For soil theory, there can be a defective microenvironment. Patient T cells overproduce interferon alpha, TNF alpha, inhibit the hematopoiesis. So successful BMT implies adequate stromal function. Regarding
go back to the
IST,
previous slide. Yeah, actually, if you look at the line just above the pink box, the levels of hematopoietic growth factors, they are increased in the microenvironment of bone marrow, right? So, which means that the soil is not all that bad, right? The problem is with the seed, that pluripotent stem cell is either damaged because of the drugs or ionizing radiation, or there is a immunologic injury to that cell and it's not capable of multiplying.
so as she has mentioned, the response rate with intensive immunosuppressive is up to 80% in cases, long-term survival in 60 to 80, relapses occur in 20 to 35% of the cases. But the limitations we have is cyclosporin dependency and clonal abnormalities with them and malignancies in long-term survivors. We use ATG and cyclosporin as combination therapy gives a better result, around 65% versus single drug with 31, and 2-drug combination is the standard IST recommended. ATG is administered through the PIC line, peripherally inserted central line, and it's acts by inhibiting this cell-mediated immune response by altering T cell function or eliminating the antigen reactive cell. Can you see the
Seen here.
PIC lines? This, can you see a faint line? This going up till the sternal angle. This one. So this is the PIC line. We check it with the X-ray after inserting it. So then after ATG, we start with the cyclosporin. Doses are 5 mg per kg per day. We have to monitor the levels. It is the trough level we have to maintain around 150 to 200 nanogram per ml. The side effects which we see are gum hypertrophy and hirsutism. LFT and KFT need to be monitored, and obviously BP need to be monitored, and it also leads to hypertension. So most of the gum hypertrophy are usually because of the poor hygiene rather than using cyclosporin. Supportive care, anemia, maintain the HP of less than 8 during the administration of ATG and less than 6 during the stable phase. Neutropenia, if develop infection, treat aggressively. The guidelines are same as we treat for neutropenia in cancer patient. Thrombocytopenia, maintain around platelet of 20 to 30,000 in the initial phase. When in chronic stable, we can maintain up to 10,000 and it is found to be safe. This is one of our patient with severe aplastic anemia with IC bleed, hemiplegia. He was managed with aggressive platelet support and he recovered completely without any neurological deficit. Here lies the importance of supportive care. So assessing response, complete response, the patient should be transfusion independent plus HP normal for age with ANC of more than 1500, platelet count of more than 1.5 lakh. Partial response, transfusion independence plus if does not meet the criteria for severe or very severe aplastic anemia. No response, still he meets the criteria for severe or very severe aplastic anemia. It's clear? So we have to wait.
You can just
till
show what
just-
are our responses.
So according to the
Show the next
experiences,
one, the last
Next.
latest data that we have.
this one.
Yeah.
So this is the latest data. 35 patient
This
with
is actually
aplastic.
also 5 years old, but this is the latest that we have published from here. Yeah.
So 35 patients with aplastic anemia, 14 very severe and 21 severe aplastic anemia. 7 were early deaths, 28% patients were finally evaluated. Median age was 10 year. At age 1 year, 14 of them responded, and response around 50% of response rate. Out of 28, 14 had responded. 4 complete response and 10 partial response. 3 non-responders, they received a second course of ATG after 1 year. Of these 3, 2 responded after the second course. Hence, overall response including the second course was around 57%. 3 relapsed after a median interval of 23 months, and the median follow-up of 15 responders was 14 months. Other therapy, additional immunosuppressive which can be used are
So, if you have seen, 2-drug immunosuppression is better than the single drug, so why not add another one? Maybe the more would be better. So people added corticosteroids, but what they found, corticosteroid increased the susceptibility to infections, particularly in the initial phase, and there is not much improvement in the response rate. Then the other drug used was mycophenolate mofetil. That's the latest one used, and again there was not much improvement with this drug. So
GCSF
growth factors,
recommendation.
mostly they are of no use, because it's not a bone marrow suppression that is occurring because of the drug therapy. It's the damage that has occurred, and you can't just keep giving stimulus to a stem cell which is not functionally correct. Okay, so GCSF etc. mostly work when, say, the bone marrow suppression has occurred because of drug therapy, the cancer chemotherapy. There at least the marrow, the stem cells are fine, they are suppressed because of the effect of the drug. They are not immunologically destroyed or something. So that doesn't work. The eltrombopag has found some place in the treatment of aplastic anemia. Not only by increasing the platelet count, it leads to multi-lineage response in some cases. So that, and please remember that in supportive care, whenever, suppose you have a question in your exam, supportive care in aplastic anemia, please do write about iron chelation, right? It's not only transfusion, infection control or infection treatment and the platelet transfusion. The iron chelation is also very important. Iron chelation, particularly in those who are partial responder or non-responder, they would receive a very large number of packed cell transfusions. So we mostly look at the ferritin levels when about 15 transfusions have been given, the way we do it in thalassemics, and if it has crossed 1000, then we start deferasirox. Deferiprone, because of the known side effect of neutropenia, granulocytosis, is not a drug that should be used in these cases. Okay. So I think we discussed a lot about bone marrow aplasia, pancytopenia, even the treatment. Okay. Any questions or anything more anybody would like to add? From any, are there any questions? He keeps getting the questions. Okay.
If you have the question, you can just read out. Yes.
Do you have a question on SMS?
He has.
Yeah, acha. Just let us know.
What about flow cytometry for PNH? Can it be an autoimmune cause?
What about the flow cytometry?
Actually, the first question is what about flow cytometry for PNH? I think we discussed. Ideally, yes, this workup should be done for PNH in children with aplastic anemia, though the PNH is quite rare in pediatric age group. Now, I might add here, even if PNH is there, depending upon the size of the clone, if the clone is not very large, then one would still give immunosuppressive therapy, right? It's not that it becomes a contraindication to do that. The only thing is that you will be more careful while the ATG is being administered, because the hemolysis due to ATG does occur more frequently if the PNH clone is there. Okay. The other question I am not able to make out what are they trying to say. What was that?
So can it be because of autoimmune even I can't?
Huh? Autoimmune. Yeah, actually we discussed that a lot of idiopathic aplastic anemia is because of immune destruction. But per se autoimmune disorders like SLE. SLE is associated with the pancytopenia in two ways. One, peripheral destruction, and second, aplastic. Bone marrow aplasia also can occur in SLE. So, autoimmune disorders can be associated, and the immune mediated injury can also be partly responsible for the idiopathic aplastic anemia. Any other questions? Are you still getting? Okay. That's it? Okay. So, I think since there are no more questions, we should close this session. Thank you, Pritam, for presenting the case, and my colleagues here, Dr. Mehto and Dr. Piali. Dr. Piali particularly presented that PowerPoint on aplastic anemia. Thank you very much.